Hi guys, Dr. Gillard here. It is Dermatology Wednesday. It's week 7, fall 2020. Talking about, what are we talking about today? The number one type of skin cancer, basal cell carcinoma, and melanonychia. So if you don't know what that is, stay tuned. Basal cell carcinoma is up first. And I must warn you if this goes, actually this is going on YouTube because our internet is down. So I'll put this up on YouTube. There are some gross pictures in here, so if you're sensitive, I'll try to warn you, but I can't promise I'll warn you ahead of time, especially with basal cell carcinoma. Melanonychia is not gross at all, but this is a very destructive type of cancer. It is the most common type of skin cancer. Squamous cell is number 2. And so it's the problem is not metastasizing usually, but it is incredibly invasive and destructive. The weird thing, it can't seem to get through endothelial cells very well, so it has trouble metastasizing, which seems kind of strange because it can get into bone, it can get into nerves, it just can be incredibly destructive. This is not one you want to mess around with. And we'll look at it, someone who messed around with it, and you'll see what happened, and it's not a fake picture. Actually, it's the next picture, so very disturbing picture. So if you're sensitive, don't turn this on in 2 minutes. But untreated, it can destroy all sorts of stuff. So here's a guy. Whoops, that's not yet. Sorry. Warning is coming up. I think it's after this one. I not put another slide in here instead. General presentation. It typically is a papule or starts as a plaque, so it's kind of a raised. That's kind of a basic starting type lesion. So it's sometimes it can be skin color, but more often than not, it tends to have a redness to it, and it tends to have an ulcer right in the middle, and that ulcer likes to bleed. Sometimes it has these rolled borders or rolled margins around it. And that's the story with it. The ulceration does bleed and it heals and it rebleeds and heals. It never heals. It's like you always have this lesion on your face and it never heals. This is actually one of the most common type of basal cell carcinoma is nodular cell carcinoma. The ulcer can get really, really big. Here's the gross warning. So I told you, pretty darn gross. So this guy was diagnosed with basal cell carcinoma, and a surgery was recommended. And I guess he kind of lived up in the sticks somewhere, like farmed, didn't believe in doctors. And then he finally came down, and the doctors were absolutely shocked. And it was he for sure didn't live much longer after this photo. But you can see it definitely is it can be destructive. There has been a 10% per year rise in the incidence of basal cell carcinoma, probably because it's more recognized, maybe thinning ozone, we're not 100% sure, but it is on the rise. Categorization has been a problem. There's 26 different subtypes of this disorder, and most authors can agree on 2 types, but you'll see what I mean here in a second. There's another common presentation. See, it's a raised lesion. It's kind of skin colored, but then it has that red where the ulcer is in the middle. And it does not always appear in the skin that was heavily exposed to UV like the other types. So it's UV related, but not heavily UV related. 33% of it occurs not on the heavily exposed skin regions. It particularly likes the nose, which I didn't put in here, but I will here in a minute. But it does like the nose. That's skin exposed. But then the eye, this is usually shielded by glasses. So it can be there on the medial canthus of the eye. Typically affects people over the age of 40. 85% appears on the head and neck. The nose is the most common target. There is one that guy let go way too long. But see what I mean? It's always kind of, it never heals. It's just a lesion that doesn't heal up. African Americans don't tend to get basal cell carcinoma. Uh, Individuals with our fair skin, blonde, red hair, and blue eyes are at greater risk. UV radiation is an exposure in most of the time, but not, right, we just said, what is it, 33% occurs not on heavily exposed skin regions. So, but it's still still an important risk factor because 66% is related to the sun. Once you have BCC, basal cell carcinoma, there's a tenfold risk of reoccurrence. So the reoccurrence is a problem with this condition. If you take it out, it does tend to come back. We'll look at those numbers in a while. May occur at a site of previous injury or burn or some kind of scar. Can grow right in that scarred up area or burned area. Basal cell gives it away. What causes it? It's a mutation of basal cells, which are stem cell like creatures that live in the stratum basale of the epidermis, and they create all the keratinocytes and every type of cell, including the desmosomes, is all manufactured by these basal cells. So they're basically like any cancer. They're a mutated and immortal basal cell that grows without control. And it can extend down into the dermis, hypodermis, and into bone. It's a very penetrating cancer. Although strangely, it has trouble getting through the endothelial tissue. So that's definitely strange. That's why it can still metastasize, but that's not typical of it, at least early on. The cause, UV radiation, is thought to mutate the basal cells, and it mutates suppressor genes. So UVB turns off suppressor genes in the region. We have genes that make proteins that attack mutated cells and destroy them, so these people don't. I took all these slides out because we're getting too far into the weeds, but one common gene mutation is the patch suppressor gene, the PTCH gene. All right, so this is the problem here, classifying these things. So here's my main books that I use: Bologna, Fitzpatrick, and Rook. And you can see, so Bologna, all three books agree that of these categories: nodular, superficial, and this morphoform, also called sclerosing, or morphiform. That's silent, right? Morphiform. But then there's a pigmented type, and there's another 20 types that won't even put in here. So we will talk about the most common, and there's just an example of how destructive this can be. And that's a basal cell carcinoma that's just eating away this ear, and it's infected all the way up into here. Not a good thing. So nodular basal cell carcinoma is the most common type. If you get basal cell carcinoma, 50% chance it will be nodular. Typically, it's not super aggressive again. It has trouble getting through endothelial cells, but it's very, very destructive. By aggressive, I mean, I guess I could clarify that word. Aggressive, it is very destructive. So that's aggressive that way. But it doesn't. Aggressive means it doesn't get into the lymph system and spread to the liver and brain and other organs. Typical presentation on the nodular type. So when it starts out, you have these little white or red, pearly white. They tend to be pearly white, actually. Papules or nodules. The key with these is you can often see telangiectasia, so little tiny blood vessels you can see. Anytime you see little blood vessels, that's not a good thing. Classically, they are said to have rolled borders. That's a strong clue of basal cell carcinoma, the nodular type. And they ulcerate as time goes by. They start to ulcerate and become kind of red and scabby, but again, they never tend to heal. Here's a perfect nodular, a beginning nodular basal cell carcinoma. See how it's got the pearly white lesion, kind of rolled border around it? And then there's a crater. It's almost like a volcano, kind of. There's a volcano crater. There's maybe some petrified lava or lava stone around it. But that's that pearly white that they talk about. And then it bleeds. It grows rapidly, or as it grows, it can grow quite quickly, and you can see these telangiectatic vessels poking up here. That's always a bad sign. Anytime you have a mole or anything, you think it's a mole, and you see blood vessels like this, even in the area, see them growing out here, this is cancer. You got to get that person to a dermatologist right away. All right, there's another one just starting out. Really good, maybe crusted a bit here. It's kind of got that rolled volcano. There would be the crater there. Looks like it's got a little crust on that. What do you do for these? The less aggressive ones can be removed by surgical excision. The bigger lesions, you're going to have surgery, and you're going to have to call in a plastic surgeon because these things can really dig down and you have to take out a lot of tissue. But here's what I mean about they're tough to get rid of. Look at the reoccurrence rates on these. For ones that are in the head, the trunk, and the extremity, about 7% of them come back. For ones that are in the scalp and on the head and on the temples, 13% and 17% come back that were on the nose and eyelids, chin. That should be the jaw. All right, so that's all we'll say about that. Let's get on to the nail now. We have to do a little bit of anatomy here because you guys know I do like my anatomy. Let's talk about the nail. The nail and the associated structures are collectively called the nail apparatus. Its job is to, that little hard nail plate that you're tapping on, you might be looking at it right now, its job is to protect the distal phalanges underneath it. The nail is made of something called onychocytes. So we know the skin, we've talked about the layers of the epidermis. The outer layer is called the corneocytes. So these onychocytes are very similar to the corneocytes. They have a lot of keratin in them, and yeah, that's the functional unit, or the nail functional anatomy of the nail. Nails are found only in primates, so just the chimps and the apes and the humans, they all have nails. The visible part of the nail is called the nail plate. The proximal part of the nail plate has a lanula over it, that little white crescent you can see. If you drill a hole through that, you're actually in the proximal part of the nail matrix, which is where all the magic happens. That's where the stem cells are. Okay. The distal part and the majority of the nail plate rests on a bed of soft tissue called the nail bed. So you have a nail plate, which is actually double layered, and then next is the nail bed. And next, underneath that, you have we have some tissue underneath that. Well, let's wait till we get to that. Try to stay on my slides here. The distal nail matrix and the nail bed support the nail plate. And there's a proximal nail matrix and a distal nail matrix. Let's take a look here. Pictures are always best. So here's the nail plate, run-of-the-mill nail plate. Here's the lanula. That covers the distal nail matrix underneath there. This skin region right in here, that's called the proximal nail fold. These are called, right here, the lateral nail fold. Hyponychium is underneath, right where the tissue starts. So if I would have to go underneath this little kind of free edge of the nail, that would be the hyponychium. And the cuticle is hard to see, but you can see a little bit of it right here. The cuticle sticks out on top of the nail plate. Right, here's a kind of a coronal view of this, or I guess it'd be a sagittal view. And you can see the nail plate, the nail bed, and when you get back to that lanula, you're actually under matrix territory. Specifically, you're under the distal nail matrix, and then we have a proximal nail matrix, which is underneath the proximal fold here. And then when you go underneath the nail bed, you get in to some collagen, and well, we'll wait till I get to my, let's try to stay on top. That's the dermis actually, but let's get to it. So here the lanula, you can see what that looks like. It's been destroyed in this nail that's been lifted off, but there's what the lanula looks like. And there's the nail bed, and the nail matrix would be right there. What produces the nail plate? So cells of the proximal and distal nail matrices. Together they create a double layered nail plate. We have a really nice picture of this right here. So here again is the distal matrix, is right here. And then here's the proximal matrix, which contains stem cells. And it creates cell, like here's like a basal cell. They're not called that though, but it creates a cell through mitosis and another one, and creates another one and another one. And they get, just like we talked about with the epidermis, they get ratcheted forward as they're produced. Because as a new one is pushed here, this whole chain is pushed, so it grows that way. And the same thing happens here under the distal matrix. So cells in the proximal and the distal matrices create this double layered nail plate. Proximal matrix produces the dorsal nail plate, and the distal matrix produces the ventral nail plate. Nice easy anatomy question, right? That's the only way it could be. The proximal matrix couldn't produce the ventral plate here. It has to be the dorsal, because they can't. They would cross. It wouldn't work that way. If you destroy either of these matrices, you can't replace your nail. So this guy hit his hand or finger with a nail, his nail plate, and destroyed it. But you can see underneath there's new nail coming up. So he didn't destroy the matrices, and he will, in about a year, have a new nail. All right, the birth of the nail plate. Onychocytic stem cells. So they're not basal cells like they're in the stratum basale, but they're similar to basal cells, called onychocytic stem cells. They live in the matrix and continuously divide and divide via mitosis to create not keratinocytes like are in the skin. They're called onychocytes. Onychocytes. And just like with the skin, as I showed you, the newborn onychocytes push forward, and they ratchet forward, and they create a kind of a nail plate that's constantly growing forward. And as they're living cells, so they have genes that make keratin. And the older they get, the harder they get. So once you get past the lanula is actually brand new onychocytes. Brand new onychocytes, and they're not very thick yet, so you can actually see through them. That's why they look like that, kind of see through. All right, so they push forward, and they accumulate more and more keratin as they go forward. They grow at about 1 to 3 millimeters per week. Toenails are 1 millimeter, fingers are a little faster, 3 nails, so it can take anywhere from a year to a year and a half to replace a nail that's been damaged. Nail growth slows with age, and if you have diabetes, they don't grow very fast. If you're old, they don't tend to grow very fast. 85% of the onychocytes keratin, it's a special type of keratin. It's called hard keratin. We don't have that in our keratinocytes. We don't have much hard keratin around. We have it in our teeth and our, let's see, where else can I think it is? That's about it, in our teeth. But animals have hard keratin in hoofs and horns and things like that. But yeah, there is soft keratin as well. The keratinocytes of the skin only produce soft keratin. Hard keratin makes up onychocytes. Makes it very, very hard. But there's some fun facts about this nail plate that you might kind of not intuitive. Keratinocytes, the fat content is 10%. Onychocytes, which is the cells that make up nails, that's only 2%. So they're pretty lean. This is the weird thing. So the nail plate tends to be 1,000 times more permeable to water than the skin. So you pour water in your skin, it beads off, and it still beads off your nails. But you ever notice when you get out of the shower how soft your nails are? You can cut your nails so easy after you get out of the shower because they're permeable to water. Therefore, you have to be careful with what does police have to be careful with fentanyl because that can just touching in your nails, it can get right into your blood, and it's killed people before. Like it can go through your skin too. It's so strong. But yeah, so that's interesting. So medications can go right through the nail quite easily. Distal phalanges. So the relationship between the nail plate, I could say the apparatus, but it's really the nail plate and the distal. There's a very intimate relationship between the nail apparatus and the distal phalanx, or the distal phalanges is plural. If you get a disease of one, you're going to get a disease of the other. For example, patients with psoriatic arthritis of the distal phalanges, it ends up in the nail plate, and you have a psoriatic nail we'll look at in a second. This is part of the reason this is because we're completely missing a layer of the skin. So, and I remember I told you at the beginning, chiropractors don't call the subcutaneous layer. There's the epidermis, dermis, and subcutaneous layer. The chiropractic boards don't call it that. They say that's not the skin. Medical boards do. So I think it probably is part of the skin. But anyway, we're missing the subcutaneous layer. So the skin is only 2-layered thick in your nail plate, where it's 3 layers thick in the rest of your body. So therefore it's easy for things to pass between the nail plate and the bone. Vice versa, if you get an infection underneath the nail and the nail bed gets infected, you can get osteomyelitis of the distal phalanx quite easily. Here is a psoriatic patient with psoriatic arthritis, the classic sausage fingers. I don't know if you guys have had that before. That's classic psoriatic arthritis. But also the nail, look at the nail plates. I mean, they're completely destroyed here. Okay, so this is manifested in the skin as well as the bone. We'll look at the bone right now. So classic psoriatic arthritis, always think pencil in a cup. It's been around since I've been in school. So psoriatic arthritis is thought to be autoimmune. They're not 100% sure, but it's an inflammatory destructive disease. Tends to affect that inner phalanx, or the interphalanges, or the interphalanx. And you can see on this one it's not affected. Right, there's or the middle phalanx, you could call it. Right, but look at this one, how it's whittled. It's whittled down to a point. So that's the pencil. And then the distal phalanx, look how wide that's got. The base of it tends to widen out. So there's the pencil in a cup. That's classic of psoriatic arthritis. But look at this person with psoriatic arthritis underneath. He's not, I mean, this is like an extreme, right? Probably should even take that out of it. This is, you can't tell that he's got psoriatic arthritis, but look at the nails. See how they're pitted like this? Sometimes you have the drop of oil appearance. It looks like a drop of oil underneath there. This isn't a very good drop of oil. But yeah, so that the autoimmune or whatever the problem is has affected the nails as well from the bone. There's pencil in a cup. Don't forget that. Dermis under the nail. So under the nail bed, we have the dermis. And it's a dermis. It's filled with blood vessels, nerve endings, and it has no subcutaneous layer or subcutis layer, all those AKAs. It has none of that. It's connected by collagen bundles directly to the periosteum of the distal phalanx. So that's sure is a strange kind of setup. There's a really nice view of the nail plate here. And then we have the nail bed. You can think of that as kind of the cutaneous or the epidermis type layer, only you don't call it that, because underneath that, then you have the dermis. So this is all dermis, and then there should be a subcutaneous layer, and there is no subcutaneous layer. You come right up to the bone here. Got it? Fun facts. Yeah, unlike the keratinocytes of the skin, the onychocytes, they keep growing and growing and growing. And growing and growing. If you don't cut them, you can look like this. I think this is the Guinness Book of World Record, the guy with the longest nails, which is just, oh my gosh, I don't know. Well, whatever floats your boat, I guess. But yeah, they'll grow until you cut them. The cuticle is actually a modified stratum corneum layer that extends over the lanula mainly to protect that matrix, because that's really soft. Those onychocytes are not fully developed, so that protects them. It shouldn't be pushed away. And you go to a manicurist and they push it out of the way. That's not a good idea. It maybe looks better, but it's there for a reason. The nail bed is a modified stratified squamous epithelium. So it is an epithelium. You can think of it as an epithelium, but it's really modified. It only has 2 layers. It has a stratum basale layer or stratum basal layer. And this is where the stem cells are that make the stratum spinosum layer, and then the cells above that are stratum spinosum layer. So these stem cells are different from the stem cells that are underneath the lanula and the proximal nail fold that make the nail plate. So there's another set of stem cells there that actually make this nail bed. And underneath the nail bed, we said, lies the dermis, and again, there's no subcutaneous layer. All right, so that's enough anatomy. Let's get into our last condition here. Let's talk about melanonychia. Melanonychia. That's melanonychia. It's a streak in the nail. So let's talk that through. So melanonychia, it's got to do with melanocytes. So melanocytes live in the nail matrices, both the proximal and the distal. Usually they are sleeping. They don't work. They're just hang out, but they're not functioning. They're not, and you remember what a melanocyte does, right? There's the melanocyte. It has these little octopus arms and injects the keratinocytes that are just born here. Stratum basale would be, the basal cells would be underneath here. They just divided by mitosis to create this basal cell, and it gets a little cap over its nucleus here, which is made of melanin to protect it from UV radiation. So, but in the nail matrices, they're there, but they usually are sleeping. They don't work. But I said usually because sometimes they wake up. And if they wake up, they do exactly the same thing here. Only instead of going up to the skin surface, they go, like if this is an overhead view, this is the nail. They would be injected and they would be ratcheted forward. And they would be very dark. So it leaves this streak right here. Right? The nail bed, does that have melanocytes? That's debatable. There's some newer research that says there are actually melanocytes in the nail bed. But the ones we care about that cause these streaks, this melanonychia, they're in the cortex, the nail cortices. All right. So the question is, what activates them? Well, I guess kind of got ahead. Again, these melanocytes are usually sleeping, but sometimes they wake up. And if a cluster of them wakes up, they start doing their job. So in this person, the nail matrices in this region right here, there's probably 100 of them right there that have woken up. These and these, they're all sleeping, these little sectors. But for whatever reason, that little sector woke up. And every time they make an onychocyte, they inject it with melanin. And they're pushed forward as more and more and more. And you get this long streak in the nail. And that's melanonychia. And they've woken up. But the question is, what wakes them up? And we're going to classify these things in a second. All right? So that's called melanonychia, aka is longitudinal melanonychia. A lot of times the authors just leave the longitudinal off, but it's the same thing. Sometimes you can have a large cluster. So maybe we had 3 sectors of melanocytes wake up here. And so now in this little person, a little kid, we have a pretty big melanonychia here, right? Longitudinal melanonychia. It's wider, and that's actually a risk factor for cancers we'll get to here in a minute. Right? The streaks can be variegated. They can be thick, thin. The thicker they are, or sometimes that's called the breadth, or is that right? Breadth, or the thickness. I call it the thickness, or the width of it. They can also be variegated, not a good sign. They can take over the entire nail plate, a terrible sign. That means it's cancerous. Here's another one. So a cluster of melanocytes have woken up in this person of color right here, and they're growing forward. Why they're sleeping here, next door neighbors, these guys are all sleeping. How come? Who knows? We don't know. Aren't 100% sure. I'll show you some things though that can wake them up, but a lot of times it's idiopathic. They just wake up and we don't know why. But well, let me keep going. We'll explain more. Terrible sign. That's cancer. That's subungual. We've actually talked about that. That's subungual onychomycosis, or subungual melanoma, you can also say. So yeah, they've woken up. But see, anybody see the bad part there? What's scary about that? Yeah, look, it's got into the skin. So this is not good. Really bad. Subungual onychomycosis, or subungual melanoma is another AKA for that. Right, and that's everything. I think you get it by now, but in this cartoon, so these are regions, and each one of these little stars probably has 100 melanocytes in it. But let's just pretend that this patient only has, 3, 6, 9, 12, like 12 melanocytes. These 2 became activated, and they're injecting all these onychocytes, and they're colored, but the onychocytes next to them are clear. Got it? All right, causes of melanonychia. So there's 2 processes that can cause melanonychia. We have functional melanocytic activation, which we'll look at that one, and then we have melanocytic hyperplasia, which can start to get scary. There we have our moles, our lentigo, and our cancer cells. But let's start with the functional melanocytic, or melanonychia. So this occurs when dormant matrix melanocytes wake up, and that's what we've been talking about, and they start injecting melanin. So this is the one we've just described, and they cause long streaks. So what wakes them up? Well, sometimes you don't know, but there are things that are known to wake these up. And this is not a hyperplasia. There's no, they're just run-of-the-mill melanocytes, and they wake up. They're not hyperplastic or they're not dysplastic. They just woke up and are doing their jobs. So definitely know the slide. What can cause, because you're going to have patients coming in and say, look at this weird streak in my nail. What the heck is that? And they're going to go, is that cancer or what's going on? And chances are it's just functional melanocytic onychia. So pregnancy, the hormones associated with pregnancy can do it. People who bite their nails, people who get manicure, so any type of trauma can set this off in some people. In your toenails, tight shoes, or trauma to your toenail, psoriasis, Addison's disease, HIV. People of color just idiopathically have these things tend to activate. People have had cancer, radiation exposure, drugs, onychomycosis, which is a fungus under the nail we'll talk about soon. And sometimes we don't know. They just wake up and start doing their thing. So people of color, it's well known that people with darkly pigmented skin have a much greater chance of developing melanonychia. African Americans, for example, over 90% of African Americans have had at least one of these, or they will have one of these over their lifetime. So they're super common. You can see, can everybody see it? It's right there. So it's just a faint little one, no big deal. Right, here's another one. See it? There's another one. We've actually looked at that one, I think, before. No big deal. Okay, now we have melanocytic hyperplasia. So this is the second category. And remember, functional melanonychia was the first. So this is hyperplasia. And melanocytes are not only turned on, but they proliferate. So it's like hyperplasia means to proliferate. Like a callus, you have keratinocytes that have gotten too big. So there's too many of them. And if you have too many of them, the chances that a couple of them are going to be activated is there. And the regions that they proliferate in, they tend to be turned on. And we don't know what causes this. Some of those risk factors I just talked about, right back here, can cause that as well. All right, but yeah, so there's an increased density of active matrix melanocytes. They may or may not be dysplastic. I don't think hyperplastic could be dysplastic. We're going to get to that category in a sec right now. So hyperplastic melanocytes, there's two flavors of them. There's the benign melanocytic hyperplasia, which is no big deal. They just wake up and there's too many of them. Then we have the malignant melanocytic hyperplasia. That's the one that you know, subungual melanoma, subungual melanonychia. I could have added that in there. Remember, subungual melanoma is a category of arcual lentiginous melanoma. We talked about that last week. All right, so let's look at the benign melanocytic hyperplasia. So two categories of this. Lots of categories in this lecture. So these are benign, but the category 1 is a lentigo of the nail matrix. So you have an overabundance of activated hyperplastic melanocytes that are active. They're secreting matrix. And it forms just like a lentigo lesion in your skin. It forms because they're overactive. They secrete melanin, and it gets pushed forward into the onychocytes, and you get a streak because of that. There's no nest of melanocytes. When we talk about moles kind of come from a nest of cells we'll look at. So you don't have nests. These are just lentigo lesions. Okay, more common in adults. But then we have the next one is nevi, and nevi is mole. So these are basically, you have a mole growing in your nail matrix. And it is, the cells are in a nest, and they secrete melanin like crazy. So you have these nests of hyperactive hyperplastic melanocytes, and yeah, so it's basically you just have a mole here. You know, what is the mole? Look at the mole on your hand. You probably have a mole somewhere. That mole is constantly spitting new cells. Those cells are turning over every what is it, 24 days or so. It's spitting cells right up at you. It looks like it never moves, but those cells are replaced constantly. Same thing here, but only the cells are not coming out of the plane of the page. Their cells are heading down in that direction, if that makes sense. Now malignant melanocytic hyperplasia. This is the subungual melanoma we've talked about before. So matrix melanocytes mutate, become dysplastic, become immortal, detach from their basement membrane. That's cancer. And they're spitting out melanin. They're injecting all the onychocytes with melanin as they go. So you get streaks of those things. And not only that, no, that's not right. They're not injecting anybody. These guys are just cells of cancer cells moving forward down your finger in a thin line. That's what these are. There's no injecting of these things. They're just mutated, and they grow like crazy. So the malignant melanocytic hyperplasia typically strikes in the second decade of life. 2% are in Caucasians, 33% Native Americans. That's a big number, right? So even more than African Americans, our Native Americans are at way more risk than any other group. And this one is not related to sun exposure. When do you become worried about a a, a longitudinal melanonychia? When do you become worried? Um, wait a minute, we're not at that slide yet. So when do you become worried melanocytic activation versus subungual melanoma? So for if the age group 40 to 60, African Americans, Native Americans are risk. The breadth, which is kind of the width of the lesion, is greater than 3 millimeters. If it's widening, it seems like it's getting widening every month. If it extends, this is the big one. We've talked about Hutchinson sign, I think. That's when it's not just affecting the nail, it's actually in the proximal fold or in the distal tip of the finger as well. Family history is a source as well. Not good either. That's a risk factor. So there's a Hutchinson sign. See how the cancer's gotten down into here, and it's all brown all the way through here. So not good. The nail splits too. The nail gets really brittle and starts breaking. These are bad signs. Signs that it's a subungual melanoma. That's a really bad sign, right? This person came in way too late. Thought it was a bruised nail. But no, look, see how it's invaded the proximal fold? Really bad. There's some more of them. See how it's invaded the tissue? Hutchinson signs. So bad signs of melanonychia. So this is the one. When do you get worried? So if the band is variegated, if the band is wide, but if it's, all the other things I said, but if the band is variegated, that's usually not a great sign. That has to be biopsied. And if the band is getting thicker and thicker, wider and wider, you can take a measurements and keep an eye on it and see. Those are bad signs. So here's a variegated, this is through a dermoscope view here. But this is, you can still kind of see it variegated, but when you get that magnification that the dermatologists have, you can see all the different colors. That was melanoma, subungual melanoma. And there's a Hutchinson sign right there on top of the variegation. Another one. It's got a biopsy, right? You don't even need a dermoscope to see that. You can see the variegations. It's really wide. That's not a good sign. And it turned out to be subungual melanoma. All right. See you guys. I think we got to be doing the test next week, right? Next week's week 7, so I assume you're doing the test. You're not going to wait till week 8, are you? One other class is done week 8. I don't care when I give it to you, but let me know. See you later.